Hello and good afternoon to our audience members. Thank you for joining this session dedicated to exploring stigma through policy, advocacy, and media. My apologies for the technical issues, but we are back on track now. As a reminder to our audience members, we welcome your questions for an audience Q&A, which will close out this session. You can submit questions in the submission box below this video feed. This session is approved for CE credit. Instructions for claiming continuing education credit will be provided at the conclusion of the summit this afternoon. With that, I would like to introduce our panelists this afternoon. We have Tracie Gardner, who is Legal Action Center's Senior Vice President of Policy Advocacy. Tracie oversees both the New York and federal policy advocacy work on LAC's core issues related to substance use, harm reduction, and criminal legal system reform. Tracie has worked more than 30 years in the health and social services policy arena as a policy advocate, trainer, and lobbyist. From 2015 to 2017, Tracie served as the Assistant Secretary of Mental Hygiene for New York State, where she oversaw the state's addiction, mental health, and developmental disabilities agencies. Tracie received a BA from Mount Holyoke College. Next, we have Dr. Joshua Scharfstein, who is Professor of the Practice in Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health, where he also serves as Vice Dean for Public Health Practice and Community Engagement and as Director of the Bloomberg American Health Initiative. A pediatrician by training, he is a former Health Commissioner of Baltimore, Principal Deputy Commissioner of the US FDA, and Health Secretary of Maryland. He is an elected member of the National Academy of Medicine and the National Academy of Public Administration. As Health Commissioner of Baltimore, he led an effort to expand access to addiction treatment with buprenorphine that contributed to a 2/3 decline in fatal heroin overdoses over the course of a decade. With respect to the opioid crisis, Dr. Sharfstein has advised states, localities, published articles in professional journals and the lay press, taught a class for doctoral students, and co-authored the book, The Opioid Epidemic, What Everyone Needs to Know, published in 2019 by the Oxford University Press. And it is also my pleasure to introduce our moderator of today's session, Dr. Nikki Lewis, an associate professor in the Department of Communication at the University of Kentucky and the communications team lead on the Kentucky Healing Community Study. Her research centers on social psychological processing and effects of mass media. She has published over 20 research articles on the selection, consumption, and influence of mass media messages in outlets such as Mass Communication in Society, Health Communication, and Journal of Media Psychology. Nikki, would you like to start us off this afternoon?
Sure. Thanks so much, Robert, and good afternoon, everybody. I'm really honored to moderate this session and want to go ahead and kick it off with Tracie and Joshua, just by kind of setting the foundation and kind of just getting some terms out into the group for the session. So what words can we use to think about when we're describing media? What are some examples of sources when we think about media in this context? And either one of you can jump in here.
So media, I mean, obviously, the first thing that comes to mind a lot is social media, and kind of the extent to which it is omnipresent, I think is one to that makes a lot of sense in this context of how it impacts public policy, how people get their information. Josh and I have lived long enough to see the evolution of papers, like from newspapers and 3 channels, 3 networks, national networks, and the trusted newscaster being the source of information, to so many various places people get their information and feel like that information is validated. What do you think, Josh?
Yeah, I think that's true. In fact, I had the opportunity to teach a class on the media and public health last term with this journalist, and we started by asking our students where they get information from? And a lot of them said, well, the news feeds on Instagram. And both Joanne and I did like a double take, like that's not where we ever get our news, but they were saying, oh, where there's this, there's that, here's this whole other thing. So it is a very, very diverse media environment. People are picking up stuff from many locations. You do have what people would call the mainstream media, the major broadcast networks and major newspapers, but there's a lot of really interesting things. And there are a lot of innovative efforts out there. There's some nonprofit journalism. There's a lot of community-based journalism going on now. So it's not all, horrible what's happening out there. There are some inspiring trends, but the media is really hard to pin down in a simple answer to that question. But Nikki, maybe we'll turn it back on you since this is something you study. Is there a way that you would say this?
No, I think you have really been on the right track in thinking about kind of how we conceptualize traditional and then what we call new digital or social media. And it is quite the difference from this kind of very restricted and almost gatekeeping function that the traditional media used to set even 20 or 30 years ago versus the more kind of flattened and diverse ways that we can cater and silo our news feeds or news consumption or information consumption patterns via social media and social media channels. So it has changed the landscape of consumption patterns, absolutely, which means not everybody is getting the same messages over and over again. And so everybody's kind of catering their information diets, which can create both complications and advantages when we think about how we want to communicate certain types of information to people. So with that kind of foundation set with what we're thinking about when we're describing media, how can you two describe the racist tendencies and racist structure in current drug policy and what you specifically see as actions that we need to take to address this using media information or other channels?
So, this has been a conversation a lot of us have been in, which is the, as a pinpoint in time. It certainly doesn't encompass everything, but so much of what we hear and have kind of absorbed, that notion of all of the goldfish in the water that we swim in, emanates from whether you want to talk about this country's history in chattel slavery, or you even want to just go back 40 years, which is, right? And so the language and images and information that have been generated and formulated and colored, if you will, by the war on drugs is huge. And sometimes it is so deeply ingrained, we don't even think about how, the sources, the origin, right? And so many different examples of that we don't even have nearly enough time to talk about. But it is important to understand that things like terms that we use about people who use drugs, the type of drugs, the way that drugs and drug use are portrayed, the difference between what is considered licit or legal and illicit, and how our attitudes about it and language being very powerful. As an example, we talk about overdose prevention sites or safe consumption spaces. And that immediately conjures people using drugs, injecting, their drugs, just disarray, chaos, and everything that is a threat to public safety. But what is also a safe consumption site is a bar. And it is the same analogy of it dispenses a substance. It is people consume it, people can go overboard, and it is a substance that causes health, has impact on health. One would argue alcohol is one of the biggest drugs that have an impact on overall individual and community health. So definitely want to defer to Josh and his role as a leader in so much of public health?
Well, thank you, Tracie, but I my esteem for you is extremely high. I'll just say that, and the work of LAC too, just incredible and so important. And I'm sure we'll talk to that, how the legal efforts that the LAC, Legal Action Center, is leading is doing an incredible job to break down stigma. But to your question, Nikki, I think it's really helpful to me to reflect a little bit on the history of drugs in the United States. And when we did our book, my wife and I, pulled out all these history books to understand things. And opium was originally, and opioid addiction was originally called soldier's disease. And the war that they were talking about was the U.S. Civil War, because the hypodermic needle came available, people were getting all kinds of injuries, and so it was the soldier's disease. And then by the end of the 18th century, it turned into a issue that affected middle class, largely white women. And there was an entire spasm of anxiety in the medical community that doctors were getting patients addicted. And the doctors were blamed more than the patients in that. But as you start to get into the 20th century, it really changes. And one of the critical aspects of this was the anti-Asian immigrant kind of wave that hit the United States in the early 20th century. And in fact, the very first law that bans an opioid only banned one form of opioid, which was smoked opium. And there were national commissions that really blamed immigrants. And suddenly the picture of who was addicted changed from, a poor, I should say innocent kind of middle class woman or upper class woman who got overprescribed opioids to kind of an evil immigrant kind of picture. And from there on, what historian David Courtwright wrote, I think it really tells the story in the United States. And he said, what we think about addiction depends on who is addicted, who we think is addicted. And, if we think it's the blameless patient, that's one thing. If we think it is somebody who we don't already like, who is already marginalized, then it's very different. And over the first couple decades of the 20th century, with the Harrison Act and the really incredible enforcement of the Harrison Act and some Supreme Court decisions, it became really clear that race and addiction were going to be very closely tied in US policy and culture. And who people thought of as addicted were people who were kind of down and out and threats to society, and were the kind of excluded from a lot of the benefits of empathy. And so you wind up with the original real war on drugs, which is the Bureau of Narcotic Control, death sentences for drug trafficking, just an incredible narcotic farms where thousands of people were sent. And you can almost trace like the rethinking of that to the 60s, when you have a lot of the richer white kids getting into drugs, and suddenly it starts to change a little bit. So you have you can almost trace how people think about drugs to who is perceived as using drugs. That may not even be the reality. And the nation's response kind of has tracked that. It is unique in some ways. First of all, America's race issue is unique. And so then the intersection of drugs and race in the United States is unique. And so in many ways, the stigma associated with drug use, the stigma of addiction, is inextricably tied to essentially the failures of US society around race and the racism that has been experienced. So to me, you have to take a step back and just see that it is a century of people thinking what we think about addiction depends on who is addicted and who we think is addicted. And to me, that sets the entire context for understanding stigma and how it works.
Yeah, those are both great points, and kind of setting the foundation of thinking about how stigma operates not only in policy, but in media representations as well, right? And so it's kind of that two-pronged stigma representation, both in policy and media. So we'll get back to specific media campaigns that have been either more or less effective in a minute, but let's set the final stage on the foundation and thinking about how the most common and popular programs that we've seen as far as policy and treatment. Can you both speak to how kind of 12-step and abstinence-only programs have influenced policy development and how stigma is kind of circulated into some of these policy and treatment decisions? Tracie, starting with you.
So I'll start with abstinence only because I grew up during the late 90s, the late 80s, early 90s of HIV. And even as that was unfolding, we saw there that this idea of abstinence around behaviors was seen as the only approach to how people behaved. I actually don't even use the term behavioral health because people use it as shorthand for substance use or substance use disorder and mental illness. But if it's behavioral, then we should include, smoking cigarettes, we should include drinking, we should include food. There are so many behaviors. But we as a society have always been hypocritical about what we say ought to be and then what we do. And in the case of HIV and now substance use and addiction, with abstinence being put as the pinnacle, it means that everything that's not it is wrong or should be punished, and that, the whole notion that people who use drugs and drug use is a moral aberration versus a health issue. But so abstinence as a goal that is both implicit and explicit in 12-step, and as somebody who absolutely is grateful for the support that I gained from 12-step in my recovery, but it is also the case that the idea of, the first one is too much and 1,000 is never enough, or all of these kinds of phrases that speak to just one, complete abstention or death, right? And so that has formulated so much public policy in terms of our approaches to whether it was in sex ed and talking about abstinence only and pretending as though people weren't actually having sex and they needed to be armed with good information, all the way to where we are now, where abstinence only includes, a prohibition on the medications that people use for opioid use disorder, the terms clean and dirty. All of that is in ways large and granular, embedded in public policy responses to our, various health epidemics, if you will. And to the extent that they're impacted by human nature and human behavior, we have tried to legislate in a way that has often not given us as a society the outcomes that we want. And so, I know maybe we'll talk a little bit about harm reduction, which is also a whole fairly new mindset about how we can help people who are using drugs, but do so in a healthy way. And again, it's this notion of harm reduction helps you do things safely that you're going to do anyway. And people talk about the seatbelt example. You're going to drive, and driving can be inherently dangerous depending on so many factors. So a seatbelt is a way that you reduce the harm of driving.
That's a great point. I would draw a direct line between stigma and this idea of total abstention, because
Mhm.
if drug use is a moral failure, then the only way to get on the other side of that is to have absolutely nothing to do with anything related to it. And so if drug use is a health challenge, for example, then you deal with it as a health challenge. If it's a moral failure, it becomes like it's either on or off. Either you're a moral failure or you're not. And that absolutism drives a lot of policy, unfortunately.
Mhm.
Going back to history, this has driven policy for a long time. And in fact, the Harrison Act did not actually prohibit physicians from treating patients with stable doses of morphine. It was in the days before methadone. A lot of physicians were reporting that actually patients could go along with their lives if they just got a stable dose of morphine. And there were some very successful clinics set up. But the Supreme Court essentially cracked down on that and said, no, that is, you're feeding people's immorality. And doctors were sent into jail because of that. And so in that way, the stigma of drug use, indirectly the stigma of race, became associated with the stigma of actually treating. And it has, lingered today. It's why, for some reason, we have medications that are used to save people's lives and are quite effective in doing that are much more heavily regulated than medications that actually have been led to a lot of addiction. Let me give a specific example that really relates to the media in this, which is neonatal abstinence syndrome. And the coverage of neonatal abstinence syndrome is very interesting because a lot of the stigma is reflected in drug use being just seen as this just absolutely horrible and irredeemable, thing. And then you have the babies that are the innocent victims in this sort of narrative that comes out. And what I would say, like the typical, maybe the traditional stigmatizing news article is just like, or if it's a TV show, it's like, the baby shivering in slow motion and how could the mothers do this? And it's just heaping stigma on the parents. But there's even another way of doing it where you have, and I've seen stories like this from some very well-meaning journalists, where they talk about the neonatal abstinence syndrome being caused by the mom's use of methadone, for example, which it can cause neonatal abstinence syndrome. But truthfully, those babies can do extremely well. The mom can be incredibly, often is just, remarkably devoted to the child. In my experience as a pediatrician, they feel like this is just an incredible gift. They've gotten their life back. And now they have a baby, and it's just a beautiful thing to see. And yet what you see in some of these stories is, and not just in the stories, but in the clinical care, is that parents are made to feel absolutely horribly guilty for causing, maybe a couple weeks of treatable, discomfort for the child. And then they say, well, and there's one story that just sticks with me. Like the punchline of the story was like, and that's why the mom is devoted to getting off of methadone as soon as possible. And it's like, no, like that is not a good goal. If, the goal is for the right decision to be made, not to get off as soon as possible, if that's going to lead to relapse and put everybody in jeopardy. And so you can see how, like, the stigma first is just the pure stigma, then the stigma becomes associated with the treatment, then the stigma becomes internalized, by people who are in this position, and they feel they're made to feel like terrible people, responsible for things that frankly they're actually moving in the right direction at that moment. And it adds up to, a really, really terrible situation.
Yeah, that's an extremely powerful example, and one that I've been especially, again, kind of the parallels between how we responded to HIV, how we're responding to overdose are so similar. So there was a lot going on, including many well-meaning pediatricians who you could tell had the belief that mom would not make the best decisions for the baby. In this case, this was about transmission of HIV to their newborns. And in fact, kind of the the vast majority of moms wanted to do what was best for their children. But during the crack era, and when we had these this notion of quote unquote crack babies abandoned by their, hapless mothers who, couldn't take care of them. And so lots of people volunteering to comfort the crack babies. And, the policies that were at play that created that phenomena were not widely known. This idea that, upon delivery, you're going to be reported to various law enforcement and other kinds of authorities meant, in that state, we didn't care about mom's health. We only cared about the baby. And what I've found especially interesting now as we're dealing with opioids and newborns and their moms is one of the things that comfort the newborns is being close to mom. We never emphasize that. And I know the nature of the drugs are different, and that's a whole discussion about how we have different policy responses based on the drug use or the particular substance. But what if that had been the approach, which is staying with your baby? Why don't we support you so you can be comfortable and then be there to comfort your baby? That would have created a whole different response, a whole different phenomena that it seems though we had to learn the hard way now, right? A lot of people had so much disruption because of those kinds of policies and those beliefs about Black and brown moms on drugs who weren't thought to be able to take care of their babies.
Well, if I could just, one story to kind of capture this, I was asked by a pediatric hospital to come talk to them about, they had some ideas and they wanted to know whether we might be able to provide some funding for them. And so I said, sure, I'll come. And they took care of a lot of patients with neonatal abstinence syndrome. I guess it's called neonatal opioid withdrawal syndrome now. So, and they said, well, what is it that they wanted to do? And actually, I got excited and I got in there and I said, for these babies, do you track whether their parents are getting the treatment that they want, as part of the care that you provide the baby? And I just got like blank stares all around. Like, what do you mean? And I said, well, probably one of the most important things for the future of this family is that people can get effective treatment and get support for the family, and that is going, if you take a look at that baby, whether the home situation is stable is incredibly important for the baby's future. And especially if a parent has out of control, drug use, helping that person into treatment and getting them support, the most important thing. And they're like, we would never track anything like that. I was like, well, what is it that you want to do? And they said, well, we just want to see whether we can, do a campaign with videos of the baby so that people know not to use drugs. And I was like, that we're not going to, like there are plenty of those, but like, don't you want to be like the first hospital that says, our outcome measure is whether the family's doing well, whether the baby's going home to a stable situation. Like that is something we can actually care about. Have you ever called a treatment program, with the mom's permission to talk about like what you're seeing? They say, well, with the moms in treatment, sometimes they're falling asleep. It's like, well, that can be the wrong dose. Have you ever called them? It's like, why would we call them? It's like, well, you could call, you could talk it over, you could be helpful to the mom there, and it was almost like speaking a different language. They were so deep into their sense that the moms were beyond redemption and the babies were their responsibility. And I think that that's another way, when they could have been, and they could be a huge resource to the families. And it's just another way that stigma kind of, works through the media, through people's perceptions. There's stories we tell about things that in the end really, really are disadvantage a lot of people.
I had to learn from someone that if you, and I wish I could remember who told me this because it's been brilliant. If you hear the word stigma, think the word oppression, and that the way it manifests, the way that how we're trying to combat it is not just about happy. I mean, it is about language and it is about perceptions and all of that. But just knowing that it is a way to keep people down, or it's a way to other people, helps to, I think, inform then what really we're trying to do in terms of anti-stigma campaigns, which is address the assumptions about people and behaviors that we're trying to combat.
Absolutely. Yeah, it's really fascinating to hear these parallels that you've brought up as kind of case studies in a way of lessons that could be learned. And so when we think about policy and we think about healthcare and treatment and stigma and how those all interplay, in the time that we have left, let's kind of really drill down into the media space and maybe think about ways we can be proactive in creating better campaigns and messages and information for people. Do you have examples of effective media campaigns that we can build on? There are several that we've launched in the Healing Community Study, but what successes have you seen and maybe lessons learned from some of the, good intentioned, but not as effective in reducing stigma campaigns? What are some kind of lessons learned there? And Tracie, you can start.
I mean, it may be an oversimplification, but it seems in the realm of having worked in HIV, having worked in criminal justice, and having also worked in the kind of policies around the addiction field, the one thing I see or have seen resistance to in the addiction field, and I'm talking treatment programs and prevention programs, is this idea that the person who has the lived experience with the drug use or in the systems that are this person is involved in because of their drug use are the best resource to develop these kind of campaigns. When they're developed by providers, both health and human services, when they're developed by well-meaning philanthropy, when they're developed by anyone else other than, or the inclusion of that lived experience, that lived voice, is absolutely critical. I mean, it's the power behind criminal justice reform that people who are formerly incarcerated with lived experience, people with HIV, I never knew anything other than people with HIV talking about and being their own best advocates at an individual and policy level. And I think that we have a ways to go to address some of those embedded beliefs about drug use, about people who use drugs, about policies that we have developed to respond to drug use. Like, there's just so much more that we could do that's better than the egg frying in the pan, right? Like, what ad agency came up with that, and who did they talk to kind of reality test it?
Yeah, I would say that people, generally speaking, don't wake up in the morning and think, I think I know how to do a complex neurosurgery. Like, there are people who can do complex neurosurgery, and it's not going to be me. But a lot of people wake up, people without any experience whatsoever, to Tracie's point, and think, I've got a good idea for an anti-drug campaign. And if one of those people has access to money, before you know it, you see something from a sheriff's office or something that they might have dreamed up that morning on the way to work. And a lot of those, when you actually test their impact, tend to be increasing stigma, driving people further from seeking help, making people very angry and seeing this as a massive moral failure rather than a treatable condition. And it, isn't helpful. I mean, I absolutely agree with Tracie that it's important for people with lived experience to be part of this. I have a lot of humility when it comes to communications like this. And I think that it's important to have great ideas and get a great group of people together. It's also important to test and make sure that your messages in your campaign are actually having the intended effect. There's no skipping that step, I think, to be effective. Curious, Nikki, what your experience is with the healings study. I would just also mention that I do think what Legal Action Center and others are doing to basically say this is a question of rights that people have rights, and the agency that people have. And I think this is absolutely a lesson from other situations like the HIV epidemic, that when people who are affected have agency, they're suing for their rights, they're demanding, they're marching. One of the seminal moments in the HIV experience was a massive protest outside the Food and Drug Administration that hit every front page and really changed people's perception of what was happening, and people were really fighting for their lives. That I think in a way the litigation that's happening represents that, and it basically is saying this isn't a question of good people or bad people. This is a question of if people deserve treatment. People should have treatment. They have a right to it in different settings, and they're being denied it. And I think that the two things that could be very important for stigma, and I do think it's really important for the media to cover it, is that kind of work, and the work to really open the medical community to much fairer treatment and more expansive treatment, but also better treatment of people with addiction, more respectful treatment of people with addiction. I think that made a big deal for HIV, and it changed a lot of society's perception of this. And the medical community has still a lot of embedded stigma that makes that very hard for addiction.
Absolutely. I just briefly to kind of touch on some of the things we've done with the healing campaign work. Conceptually, from the top down, it's been about reconceptualizing substance use into a chronic disease like cancer or diabetes, and reframing that into a remission and recovery narrative. You wouldn't deny somebody insulin, you wouldn't deny somebody treatment for cancer. And so to reconceptualize it as a disease that is treatable, and the personal narrative component in our campaigns, as you both referenced, is extremely important. Having individuals with experience, with lived experiences, telling their narratives and actually giving that story and identity has been crucial in breaking down some of the walls. And in our communities, when we use real local people that live and work in those communities, it takes a lot of guts and courage to put yourself out there, to put yourself into those campaigns and those stories, but they have been the most effective and have resulted in the most engagement. So from the ground floor, those have been some successes. We're down to about 5 minutes left, and I hope the attendees can get maybe some takeaways from both of you as to next steps and what you would like to see in the future, and whether that is, recommendations for how attendees can interact with their own communities and local media on these issues, or whether it's, any sort of practical advice that you can offer. Tracie, I'll give it to you first for a couple of minutes to kind of give your last thoughts, and then we'll toss it over to Josh.
One of the things that I definitely wanted to encourage people to interrogate, self-interrogate, but also observe, is for those of us who have benefited from being affiliated with 12-Step. And again, such great gratitude for that resource, for that network, for that support. But technology has changed 12-Step. It's changed recovery, because, the opposite of active addiction is connection. And one of the quickest connections that were made when COVID started really unfolding was the recovery supports. And 12-Step got online, I think, some of the first. And so this idea of abstinence only that would be articulated in a way that would drive people away versus bring people in. Like, how do we, in this day and age, telling people that they either stop or die, or telling people, why don't you go out if you don't think you're an alcoholic and addict and test the waters, is consigning people to death. Right? So some of it is about really the 12-Step model is always going to be a benefit to many people, but it has come into this era now where we have to question how that lives are critical. People's lives are critical, and that that support can't be conditional on their ability to abstain, right? Keep coming back really means keep coming back in whatever condition, whatever way you are, because you are valued as a person who is struggling. And there's no judgment, right? So that's only the thing I would leave, because there's so much of 12-step that's embedded in our entire treatment industry, in policy, in law enforcement, in the courts, you name it, it's there. But for those of us who rely on it, we get to start thinking about how we can ensure that it really, really can meet the needs of people who need it most.
Absolutely. Thanks, Tracie. And Josh, any parting thoughts?
Sure. Maybe one parting thought for traditional media and one for our non-traditional media category. For traditional media, I think it's really important to follow up with reporters and to be very aggressive, frankly. I mean aggressive in the sense of like very engaging with reporters, not in any other sense, but like, to get right back to them if there's a story that uses stigmatizing language, doesn't provide a full picture. I've written a lot of reporters and I said, you've written a story about people who use drugs without mentioning any kind of harm reduction or treatment. So it'd be like writing in 2022 about HIV and about this horrible story of somebody dying of HIV and not even mentioning that there's treatment available. What happened? Did they not get treatment? Were they not eligible for treatment? Did insurance not cover it? Like, I'd want to know. It's the same situation. Like, have people been able to access services? Like, where's that part of the story? It doesn't mean you can't tell sad stories, but tell them in the context that help is available and don't make it just seem like this horrible morality play. What's actually happening there. So I think it's important in a respectful but persistent way to be engaged with people who are covering these issues. And I don't just mean in this a reporter. It could be like the newsletter from the local hospital that is written in such a way to make it to pretty much stigmatize. We have some great service because of this horrible thing that these people are doing. And instead of you can say, wait, why did you tell the story that way? What's going on in a better way? And then you've got the non-traditional, and that's really these days about everyone telling the stories that they want to tell. And I think it's important for people to be familiar with stigmatizing language, use person-centered language, tell the story of people who've been able to, really help others and help themselves, and particularly, if you're up for it, be working to spread those kinds of stories, using all kinds of different social media, maybe even an Instagram account. For those of us who don't use Instagram, just to know what our children are up to. But I think I do think that there are more opportunities than ever for people who care about these issues to have an impact, and I think you should take them, but at the same time realize that these narratives are everywhere, and whenever you have the energy and the stamina, speaking up about it can make a difference. A lot of times, especially now, I think people will listen. I think that the barriers are starting to break down a little. People will be open, and I have definitely had success saying, that's not a term I would use anymore. That's not a term that's used anymore. You should cover treatment as part of it. You should think about these other stories. The most, you can get in there. I do think that this is a moment to push at every turn.
Thanks so much, Josh. And I'm going to toss it back to Robert now to close us out.
Thank you. Thank you, Joshua, Tracie, and Nikki, for your thoughts and commentary this afternoon. We are very appreciative of your time. Thank you to the audience for being so patient as we work through some technical issues. This does conclude this breakout session on addressing stigma through policy, advocacy, and media. We will now be taking a 10-minute break before the second round of breakout sessions, which will begin at approximately 2:10 Eastern Time. Breakout session 2.3, Addiction, Stigma, in the Carceral System, will be occurring in tab C, this tab, during the next session. As a reminder, instructions for claiming continuing education credit will be provided at the conclusion of the summit this afternoon. Again, it's been an absolute pleasure being in the room for this conversation. Thank you everyone for joining us. Enjoy the rest of the summit programming if your schedule allows.